Hello, and welcome to the BCN and Friends podcast, where we have real conversations about learning, leadership, and the lived experiences of nurses and healthcare professionals across the emergency spectrum. Each episode, we sit down with thought leaders, BCN certification holders, and industry experts who share their stories, their insights, and the challenges that shape their work. Our mission is simple: to amplify the voices of those making a difference every day, because your experiences drive progress, inspire others, and shape the future of nursing. We're here to honor that in every episode. Sometimes funny, sometimes serious, and always valuable. This is BCN and Friends, and we're so glad you're here.
In this two-part episode, we are joined by Marcina Doze and Shannon Krebs. When their community lacked local forensic resources, Marcina and Shannon stepped up to create change. They unpack the clinical, legal, and leadership lessons behind building a successful SANE program, and how nurses everywhere can improve forensic care at the bedside. This episode is called Start with Believing: Doing the Right Thing for Forensic Readiness, Part 1.
I'm Holly Briggs, a professional development specialist at BCN and one of your hosts for today. I'm joined by my co-host, Michael Dexter, our Director of Professional Development. Hi, Michael.
Hello, Holly.
It's great to have you with us. In this episode, we're joined by Marcina Doze and Shannon Krebs, two nursing leaders whose paths intersected to address critical gaps in forensic care within their communities. This conversation is packed with real-world insight, leadership lessons, and a powerful story of advocacy that I can't wait to dive into. Michael, could you please introduce us to our BCN friends, Marcina and Shannon?
Yeah, absolutely. Marcina Doze is an emergency and forensic nurse with more than 4 decades of clinical experience, serving as a sexual assault nurse examiner since 2005, and as a certified legal nurse consultant and expert witness in forensic cases across multiple courts. A national leader in forensic nursing education and advocacy, she's held leadership roles within IAFN and ENA, contributing to legislation reducing sexual assault forensic exam kit backlogs, and continues to shape the field through teaching, policy work, and courtroom expertise. Shannon Krebs is an emergency nurse leader whose career began in the U.S. Navy as a hospital corpsman and has been defined by service, clinical excellence, and advocacy. And today she manages the Malbis Freestanding Emergency Department and played a key role in building Baldwin County's sexual assault nurse examiner program, expanding access to compassionate, locally available forensic care for survivors of sexual assault. Marcina and Shannon, welcome to the BCN Friends podcast. It's a pleasure to have you with us.
Thank you for having us. Great to be here.
We have a lot of questions to dive into, you guys. And I guess most of the time in the podcast, we just start off with like, how did you end up here in nursing? So we're going to start there and then kind of weave our way. But the question I guess I'll ask both of you is, what initially drew you to nursing? And at what point did you realize that forensic nursing was an area that you could make and that you would make a very unique impact? So I guess we'll kick it off with Marcina.
What drew me to nursing was my mom and aunt were both nurses, and those white uniforms and white stockings and hats, I never lost my all of that from the time I was a very little girl until they retired. I never, ever lost that. Every time they walked out that door, I was just in awe of it. So that's what drew me to nursing. Life got in the way, and I did some things before I went back to nursing school, but I still always remembered and I did start nursing when we still wore caps and white uniforms. So just so y'all know, I did get to do it for a little while. And as far as forensic nursing, I was an ER nurse. That was my first love. I was fortunate enough to be the actual first nurse grad that got to come into the ER in Pascagoula. I worked there as a registration clerk, and Dr. Allen allowed me to come in, and he paired me with an LPN that had been there since they put the walls up. After being an ER nurse for about 20 years, my husband retired from the Navy and became a detective, and they didn't have any sexual assault nurses in the area. So he volunteered me. And so I was like, oh no. I don't know anything about that. And so they sent me to school, and I spent a month with the people at Quantico, came to Kansas City. I spent a month with them, first doing adult, adolescent, and then the skills lab and courtroom, and then pediatrics and the same skills in courtroom. after that, as I went back there and started being a thing for them, it became a passion, not just a job, but a passion. You know, it goes so hand in hand with domestic violence. These people come in, and when you get the story, it's just heartbreaking, the things people are with. So that's how it happened.
What about for you, Shannon?
It wasn't always my first intention, but as a very young teenager, unfortunately, we had a personal tragedy, and my younger sister, Heather, she passed away on an ATV accident. And it was really from that time, being 14 and being involved in an emergency and trauma medicine and being exposed to that, that I sort of knew that that was my calling, because I wanted to better understand all of the things that went around that. Was drawn to, when I went into the Navy, they offered jobs, I took tests, and clearly the medical field was where I scored highest. So it was just a very natural kind of evolution to go into the medic and medical field while I was in the military, even though I specialized in pharmacy, still ran sick call and all of that. Had a little bit of exposure with sexual assault at that time in reporting and assisting other sailors getting to those resources. Then moving out of the Navy, I was able to fortunately stay home with my children, two of which are 2 little girls and a little boy. And once they began school, I went to school myself and pursued my nursing career pretty quickly. After I did the 8 months in med surg, made my way pretty naturally down into the ER. And I've had my entire career in emergency medicine. Forensic nursing and emergency, they do kind of go hand in hand. Oftentimes, a lot of our survivors will show up into the emergency room. So that was really my first very up close exposure with a lot of these patients. And working in Baldwin County my entire career, pretty quickly, I realized the lack of resource that we had working in the emergency department. When these folks come in and you want to do everything on perhaps their worst day of their life, and realizing that they need to go to another state or another county for this resource. That was nearly 15 years ago, and I realized we had a major gap in resources in our area.
I'm looking forward to getting into more of the details on that gap, but thank you for sharing that, both of you, and Shannon, about your sister. I've had so many conversations with people that say they went into nursing because of a family member situation, and certainly sorry to hear that happened. And I'm sure in another way, it's made such a extremely profound impact on so many others for what you've been able to do as a result of that. So thank you for sharing your stories, both of you. And I think that there's a lot to learn about many components of emergency nursing, and would love to dive into that. But of course, we want to know a lot about the forensic nursing and SANE programs that you're working in. And, maybe starting out, you both helped to create and launch that forensic nursing and the SANE program through Malbis. And so initially, what were some of the problems that you were facing, the things you were trying to solve? And then what were some areas that you found were really the big catalyst to make it get up and moving and get going? What were some of the big helps along the way to push that?
As I mentioned, of my entire nursing career, I've been here in the area in Baldwin County in South Alabama since 2005. And identifying the issue, speaking to other colleagues throughout the years of what were some of our barriers and why didn't we have the resource, realizing that there's just a lot. There's a lot of moving parts. What I realized, it's not just a hospital system or an emergency department. It's really the collaboration of many, many community resources in order to speak to the ending success and longevity of the program. There's been a lot of previous attempts that I had heard of with really, really great intentions, and they just didn't have the buy-in from enough community resources in order to be able to maintain over a long period of time. I work with several nurses and nurse leaders that have tried themselves to get this off the ground. And I would say one of our biggest barriers was going to be funding. Who's going to pay? Who's going to pay for call? Where are our SANE nurses? Who is that? Our closest resources for us at the hospital I was at was 45 minutes to an hour away. Where did they get that training? How do we become SANE? How can we get this here? So you start asking those questions from your other colleagues, and you start realizing, at least for me in our area, that on top of funding, the other biggest barrier for us was realizing that the community didn't realize that the resource wasn't here. Most folks and residents think that if this was to occur, you would go to an ER and you can get the things that you need and the evidence collected, and that resource is commonly available. You would have those trained employees there, and that's just simply wasn't the case. So once I can educate our community leaders, my hospital administration, of the actual lack that nobody is doing this in Baldwin County, and we have a lack of reporting because of that. Patients will come into the ER, we can manage their medical needs, but when they learn that they need to go to a neighboring state or they need to go to a neighboring county, there's a lot of resistance in going and reporting. What we found was when talking to the DA's office, our local women's shelters, is kind of everybody kind of just given up. You know, they know that Baldwin County doesn't have it. They know that a lot of our systems had attempted to do it. They realized a lot of the barriers and they just didn't have the answers on how we can get past that. I think our biggest key breakthrough was when we had the support of our local DA's office. They approached all of us local hospital systems. And fortunately enough, I work for infirmary and they took that on. They took that on and said, you're right, we need to do this. And whatever we can do to do this, they were willing to support. Having a hospital administration that realized the issue and was willing to step up to the plate really paved the way for our successes.
It's great. Thank you for sharing that. I would love to hear a little bit, Marcina, from your perspective on growing those. You know, Shannon had mentioned, like, who are the SANE nurses? How did you grow that aspect of it too?
Well, first off, let me say that SANE is not a moneymaker. It is not ever going to give you funds. So getting the hospital system to buy into this was hard. So Shannon did an excellent job getting those people. We talk about it all the time, that we are so fortunate to have leadership that will listen to what we're saying. So that's been a miracle in itself. And I think this whole program's a miracle. To answer your question, you know, we didn't have SANEs, and it's a long way to anywhere from here. And Baldwin County is about 110 miles long and 58 miles wide. And it's like 3 different counties in one. You have the beach, you have the Eastern Shore, and then you have people in the north. And so you got to get everybody to buy into all that. And so we were borrowing and stealing nurses from people. I went over there to their South SANEs and said, I need nurses. Shannon and them had already gotten nurses that were at one of our sister hospitals that had a couple of SANEs that worked at South. So we begged and borrowed until we could get. I called a friend of mine, Charlotte Sharp. Y'all may know her. She was a previous ER nurse, but she's the forensic nurse from Mississippi. And I said, who can I get to teach these things? We have no money. I can't pay for this. And she said, Marcina, you're a SANE A and SANE P. You can teach this. I'm like, she said, you've taught for me, teach it. So anyway, long story made short, she sent us a lot of the information. We made it our own, applied Alabama laws and rules, which I had to learn. And that's how we started getting nurses. I think administration thought I had lost my ever-loving mind when I said, I'm going to teach 10 people, and if we retain 2 of them, we have managed. And so we did, and we have, and now we're having another class, and so we're building our own. We're bringing them in and mothering them to they get where they need to be. IAFN has a lot of resources that we can go on and will help us set up programs and teaching and getting our CEUs and all this sort of stuff. So that's what we're doing. We just started at the beginning and worked our way where we are today. We've been open a year.
I love how both of you are just saying that it took more than just one person wanting this to happen, more than just one person or 2 people having a good idea, 3 people saying, oh, this is a more than decent plan. It took probably hundreds of people within your community and surrounding your community to say, no, I'm actually going to put my support behind that, whether that be leadership to, open the doors to say, like, yes, we want to bring this program in-house. We want to do this. We want to partner with our community, whether that be the community itself saying, hey, we don't have this. How can we support this? What can we do to make connections? How can we see that the funding is appropriated to be there? Whether that be your civic leaders who then make the decision to say, like, no, we want to be known as a community that actually helps victims that are walking through through this terrible tragedy and trauma. It takes all of these different parts and pieces getting on the same page and having this like, yes, we are going to do this. And you see it oftentimes and you'll hear about it in the news. There's this great thing, this great program going on, and then it fizzles out, right? And we see it. And I mean, I see it in my own community where someone had a really great idea and then it just fizzles out. What I love is that you guys are building in kind of this sustainability where you're like, look, we're continuing to have classes. Yes, it was great that we got these nurses. It was great that we have like these initial people come in and stand with us, but they're going to move on. So we've got to get people kind of in that pipeline of learning. We've got to continue to sustain those who are there and really building a program that's going to last, because sadly enough, these types of incidents, tragedies, these traumas, they're going to continue, unfortunately. And so you've got to have that program there to meet them. You have so much to be proud of. I think it's amazing to see anything that you've kind of dreamed up and planned out and purposed come into, like being, but then also like, okay, we've got to continue to feed it to keep it alive. I love to hear that. And honestly, we could spend pretty much the entire podcast just talking about that, because I think there's just a lot there. We have listeners who are going to be like, okay, this is great. Maybe they want to move to Alabama. I don't know. Maybe they're like, these nurses sound great. We want to go. But if they can't move and can't come hang out with you guys, let's talk a little bit about like how they can incorporate something into their own practice. So I guess my question is, how can nurses recognize when a patient encounter crosses from that routine clinical care into maybe forensic significance? Meaning maybe you've had a patient who in triage, it was moving fast. Maybe they didn't even mention that like, hey, this is actually what happened, or maybe they just didn't feel comfortable at the time, or maybe they weren't, maybe that's not even why they were deciding to come. Maybe they're just like, hey, I just want to get this looked at and I want out, right? But maybe that nurse is sitting down and they're having this what they consider a routine clinical care, coming in for this. Then they start to go, maybe this is something else. So what do you guys suggest?
First off, I use the term start by believing. And if you're an ER nurse, you have a gut. And if your gut tells you this is not right, something's wrong. I mean, how many times have ER nurses, as an ER nurse, I would go to a doctor and say, I don't know what's going on, but this ain't right. And not even sexual assault, just anything. Patient's not right. So we have pretty good instincts in the ER. So I tell ER nurses, if you think it's not right and you can't put your finger on it, but you're getting close to the term of sexual assault, call me. Because 99% of our ER nurses do not have time to pull up a chair and sit down and say, let's talk. You don't need permission to call us. You don't need anything. You just call us. We can come in. They laugh at me around here because I can be pretty old, cantankerous nurse. And, but when I walk in that room, I want to sit down and talk to them and start by believing. That's my big thing. That's what I teach. And just kind of look at some of the signs. You got a husband or boyfriend that doesn't let them talk. You got a patient that's balled up in a ball protecting her inner core. Every time you ask a question, someone else answers it. My suggestion to the ER folks is call me. Just let me have a go at it. If it's nothing, I'm going to go back to what I was doing before and be fine. Patient may not have a clue what I was doing there, but we give them every opportunity. Most of the time, what I find is regardless of if I get down to the fact of doing a kid or anything like that, they need information. I can tell you that ER nurse has picked up on something and the patient needs information. We're going to get them the resources they need. In domestic violence, folks, we see them 5 to 7 times before they're going to admit. That's not a very good number, but that's what happens. And they come in for sore throats. My ears hurt. I have a sore throat. I have chest pain. Those are the kinds of things that they triage for.
Yeah, I think from a leadership standpoint, when you don't have a SANE in sight and you have a suspected person, is growing our resources for my employees so that it's okay if you don't have the answer, but we have a resource that we can call. We have local shelters we can call. We keep pamphlets here. Because like she mentioned, a lot what we find is that they won't report initially, but we will see them several times. And, this might be their one-time access for that toe pain that they needed to come in to get them in front of a healthcare worker. So if they're not able to have that conversation, at least knowing that we're empowering our ED nurses to educate our victim about what resources are there for the future if this is not a visit that they decide that they would like to report something. The biggest lesson with this is honestly going with your gut, escalating concerns to the provider in real time when you can. You'll never know who's going to make that connection with someone. It could be the triage nurse, or as we know, they could have a whole different story in triage. And then when you get to the bedside, your primary nurse gets a completely different story. When you see deviations in story, that's another red flag to listen to. But honestly, going with your gut, as vague as that sounds, we all know as nurses what that feels like. Escalate your concern.
Just as you're speaking, Marcina, I think you said that it's been a year now that this program has been up and running. And I don't know if you can or want to share any specifics, but just out of curiosity, are there any examples of some specific times when somebody went with their gut that you saw a really big outcome? Or have you seen anything where on the flip side, all the signs were there, even the documentation might have been there, but it just wasn't recognized in clinical practice?
I think sometimes nurses just don't know what to do or how to react to that. We actually had one at our mother hospital, if you will, at the main. All the things you say will never happened the first week we were open. But they did have that happen. Lady came in for multiple complaints. And in the course of this whole thing, the nurse starts talking to her over there. And the next thing we know, we have a SANE patient with multiple medical complaints and sexual assault. Very non-compliant. And the nurses were like, okay, what do we do now? Where do we go from here? So at that point, they transferred her to us over here. She came by ambulance to us. To say that made a change in our program, it really has. We bought a rolling bag that we can put our equipment in and now go rather than have them, because that wound up being 4 ambulance rides for this person to get her here and back over there and back home. So that made a change, but it was one of those things where the ER nurses immediately were like, oh my gosh. And then somebody said, oh, they have SANEs over it. I saw a flyer about that. And that's how she got here.
Yeah, just an example of what would have Nora processed before our program of a year ago. That patient most likely would have been either stabilized and transferred to a neighboring county or discharged back home and told that they needed to follow up to find that resource. And it's just not acceptable. It's just not acceptable for our patients.
Well, I'm only going to ask one more question. I'm going to turn it back over to Holly, but I do have one more question while we're on this line. And that is, as a brand new nurse, I remember being told by somebody that anytime you have a patient that's experienced a sexual assault, you want to document as little as possible because the chart will go to court and you don't want your name all over it. So what are your thoughts on that? I know you both have thoughts on that idea.
That's our number one barrier for nurses, because y'all know that nursing 101, very first day of nursing school, they say if you get a subpoena, you have screwed up. So when I walk into an ER like we did here and opened this program, I went around and my first line was, okay, who's going to be my next SANE nurse? And the response I got was, I'm not going for it. Well, okay, let's back up. First off, they don't really always go to court, and we need to help these people. But it's a process to get these nurses to understand and feel comfortable with the fact that we're going to teach you what you need to know to go set a court. And it doesn't mean you screwed up. You've done something good.
I think one of the most meaningful things that you had said when we first met, and it really got, because I'm not a SANE trained nurse. And I think that one of the most important things that you helped me understand was what we were always taught, like you, Michael, in school, put the lease, because that's going to court and you're going to have to testify to that. When it's truthful and it's factual charting, you're not defending care that you gave. You're actually the expert in that moment about what you observe. And there is a difference when it comes to SANE nursing and regular ER bedside nursing, that rather than defending something that you may have done wrong, it's a completely different sort of testimony. when you are the expert because you were the one in that room and you are testifying to the observations. That's it. It's completely different.
Yeah, and the other thing I try to tell them, especially when I teach, what I tell them on the first day in there is remember that you are the expert. You get in a courtroom, you know more than anybody in that building about sexual assault, and you are there to educate other people. You're not necessarily trying to defend yourself. You're just reading what you put on the chart. But my job is to educate that jury and that judge and everybody else in that courtroom about why it's normal to be normal. Because that's the first question I get. Well, what if we don't find anything? Well, you may not find anything. There may not be injury, but it's normal to be normal. And we have to educate people on that because people watch too much television. And they see, it's solved in an hour and there was terrible injury that required major surgery, all this kind of stuff. So we're educated more than anything else when we leave the bedside, we educate.
Love the real world examples that you shared, because I truly feel like every single person who's ever worked in the hospital in any type of critical care or emergency environment, when you were like, yeah, we were open our first week and all this stuff happened. I'm like, of course it did. It's just like when you go to a class and you learn about something, that patient is on its way. Like the first time you have like a light bulb moment and you're like, oh, I think I understand that more. A patient's going to come in and they're going to test your knowledge and hopefully reinforce it. But I was like, of course it did. But I also loved that tail end where you talked about just really leaning into what nurses do naturally. We naturally want to educate. We want to make sure that our patients understand what's happening. We want to give them resources and help them be able to take the next step, whatever that might be, right? And for forensic patients, whatever that follow-up might look like, whatever resource next step for them. But I also like how you talked about being in the courtroom. It's not the same as, being called in and questioned about whether you did something right or wrong. You're really just being the voice for an assessment that you made. And to your point, when it's truthful, when it's what you saw, what you did, like there's really not anything to defend, right? It is what it is. And that aspect of saying like, no, you're actually just educating people about that exam, about what was written down. So maybe they can ask a person questions, right? Because you can't really ask a document, but you can ask a person. And I think framing that in a way where it really is just more like, no, you're not defending it. You're speaking to it. You're maybe helping people understand it. You're educating about that. I think it helps to take away some of the fear that comes up when this whole litigation and lawyers and a courtroom, like it all sounds a little bit scary. And so I think framing that in that way helps a nurse look at it differently, but then also approach it with a mindset of like, I'm here to actually do what I do every day as a nurse, which is just to educate and to speak to the good work that was done. And to me, when you take away some of the fear, it hopefully will help you to be more confident, to feel that expertise, to be able to speak with a sense of purpose. And, I think about that patient who was a victim of this terrible thing. And to hear that someone's sitting in there speaking confidently about their assessment, I think that would just give such a relief to that person to know that they are going to take care of this part. It just makes my heart so proud and so happy for your community and for you guys. Like, wow, what an amazing thing y'all are doing. And hopefully this conversation, it will inspire nurses who maybe they've thought about forensic, or maybe they've come across a patient and they're just so moved with compassion and want to dive into this. This conversation will lead them to maybe alleviate a little bit of their fear. And thank you for listening to this part one of the episode with Marcina and Shannon. Stay tuned. The next part of this episode will drop in just a couple of weeks. And we hope that you join us as we will close out this episode with them. And we have even more packed into this second part. So don't miss out. We will see you in part two with Shannon and Marcina. You can subscribe, share, and join the conversation by scanning the QR code for Learn updates in this episode blog. You got a topic you'd like us to cover, you can drop us a line at bcn@bcn.org. I'm Holly Briggs with Michael Dexter, and we're proud to celebrate your dedication to nursing across the emergency spectrum. Until next time, stay curious, stay connected, and we're out.